So let's move on to our next speaker, and we've got now a professor, Professor Catriona Waitt. Waitt, who's a professor of clinical pharmacology and global health. A bit like me, I suppose. You can see two titles, and she's going to be talking about the importance of clinical populations in addressing bias related to protected characteristics. Now, she has a major interest in drug dosing and safety in populations that are complex and often neglected for clinical trials. And as I mentioned earlier, there are some populations who never get a chance to take part in the clinical trials, because if you imagine how clinical trials normally take place, they're normally on a sort of university hospital setting, and people normally invite the usual suspects to take part in these clinical trials. She's also interested in, for example, pregnant and breastfeeding mothers and infants. And her fellowship, which is maternal and infant lactation pharmacokinetics, explores the transfer of a range of anti-infective drugs to the mother, from the mother to the breastfeeding infants. And I'm going to stop waffling now and let her tell you a bit about her research, and then again we'll have questions afterwards. So over to you.
That's great, thank you very much. And let me also just share that screen. The moment when you fear it won't work, but hopefully it's there. So thank you very much for the invitation to speak at this important event. And Maria Augusta has laid the landscape by talking about the people who do research. I'm going to take a slightly different angle now and talk about the people that we do research upon. And yes, Winston, the reason I'm a professor of clinical pharmacology and global health is because, again, we wear many hats. And one of my roles increasingly is advocating for this equity of access to research. And so my grant has two sides. It has the science, and it has this Attaining Equity of Access to Research grant, which is subtitled At the Equator, and the social media tags are on the title slide. So when you think about pregnancy and breastfeeding, we talk about populations that are excluded, but this is not a special or a minority population. Around half of the world's population are women. And most women go through at least one pregnancy at some point. So actually, everybody deserves access to evidence-based information on which to make informed decisions about their health. It's essential we do it, and it's essential that we do it well. If you think about it, most women go through a pregnancy, and it is estimated that around half of all women require some kind of medication during that pregnancy. So, of course, women who already have chronic medical conditions requiring medication do become pregnant and will choose to breastfeed. In lower income countries, we think of all the long-term infectious diseases that are there. But in high-income countries such as the UK, we increasingly are seeing older mothers with pre-existing heart disease, maybe type 2 diabetes and other comorbidities becoming pregnant, perhaps women who would have been advised years ago that pregnancy might not be safe. And of course, a woman who is already pregnant or breastfeeding might become sick and require medication for either an acute or a chronic illness. So we need to have that evidence. One of the concerns in pregnancy is whether the dosing is okay, because obviously you go through a lot of changes, you get a lot bigger, there's more fat, your cardiac output increases, your renal blood flow increases. And the study of drug concentrations is what we call pharmacokinetics. So that's just the movement of drug from one part of the body to another. And this systematic review, it's 6 years old, but it'd be pretty much the same today. You can see from the y-axis that the number of pharmacokinetic studies done in pregnancy for all classes of drug are pretty small. You can see way more studies for antiretrovirals than other classes of drug. And I would like to point out that the center of gravity of excellence for pregnancy pharmacokinetics is actually in sub-Saharan Africa. And we need to think about bidirectional global health partnerships. But that is perhaps an aside. What this graph doesn't show is the quality of the studies. Many of them are actually quite poor. And there are some instances where the study design the conclusion that is drawn from the data can't really be supported because the study was quite badly designed. And again, the studies in HIV tend to be of the far higher quality. So this comes on to the question of whether or not it's ethically okay to do studies in pregnancy and breastfeeding. So when I tell people what I do, often their first question is that ethically okay? But I want to try and get you to think this through conceptually and maybe think of it a bit differently. So in blue is a population of pregnant women who may potentially benefit from a new drug, but we decide that actually it's best to do a clinical trial, and that's the population represented in green. And by doing a clinical trial, I've got carefully selected participants who have consented. I've got increased safety follow-up. I've got an independent safety monitoring committee. And at the first sign of any safety, we'll review the data and we'll stop and we'll pause and we'll look at it. And if need be, we could stop the study. So risk is always there, but I see it like keeping a wild beast caged in a box, and if necessary, we can almost terminate it. But if we don't do that, and we just start using a drug in a community where women have high fertility rates, low uptake of contraception, and so forth, eventually pregnancy exposures will occur. But these will occur outside a trial setting. We won't really be following them up. The pregnancies may present late. There won't be protocol specified guidance on what to do. And so by the time there is actually any risk, it's a lot bigger. The new drug might not work, or it might be toxic. And that's not all. There will be some women who say, actually, I'm not taking that drug because there are no data in pregnancy. So they run two other risks. They run the risk of older, less effective, more toxic regimens, or potentially no treatment at all, so untreated disease. So what you can see is that by not doing studies in pregnancy, if a pregnant woman is likely to take a drug, all we're doing is shifting the risk from the research to the clinical sector, where we can pretend it doesn't exist. And as researchers, we can say, well, it's not our responsibility. But actually, that is not ethical and it is not right. So if you think of the conventional bioethical domains, principles of justice, are there systematic disparities in the evidence base for pregnant women compared to other groups? And if so, what factors influence that disparity? I've already talked about autonomy, informed choice. How can somebody make an informed choice if we have not got that data? And so are we curtailing someone's autonomy because we haven't done our work? Non-maleficence is interesting because most of us went into caring professions because we want to do no harm. And indeed, one of the main reasons people say they don't do studies in these groups is because they don't want to do harm. Sure, but you can actually inadvertently put somebody in harm's way by not having that evidence. And that's almost the direct opposite of beneficence, which is when we want to act with the intent of providing benefit. So a typical example would be a drug like rifampicin, licensed in 1971. It's a major component of first-line TB treatment, and most cases of TB occur in parts of the world where breastfeeding is the only affordable, feasible, acceptable, sustainable, or safe option. So rifampicin is used in breastfeeding populations. So you think there must be data to support that? Well, there's one study from 1969 where they gave some women, or a woman, a single oral dose. There's no real details about that. And as far as I can see, nobody has measured the concentrations from breastfed infants ever. Yet, the LactMed, which is an NIH-funded initiative which draws together all the data on lactation pharmacology, it's a wonderful resource. I recommend it all the time. But it takes that data and it says that, well, there's low levels of the drug in breast milk, unlikely to be harmful. You can use it. And I would like to raise a question. Is that evidence, one participant in 1969 without much detail, is that really sufficient to draw conclusions? Can you think of any other situation where that would be considered acceptable? And yet, for the breastfeeding mother living perhaps in poverty in a low and middle income country, does anybody care? And that's where we need as a community to really make sure that nobody is excluded from research. I'm talking about pregnancy and breastfeeding, but you could include other groups here. So how should we actually do this work? it's essential we do it, but it's also essential we do it well. We start with communities. What are the questions within the community? What drugs are women taking? Are they taking herbals? What are their concerns? Then, as clinical pharmacologists, don't worry, I've got a minute and a half left. As clinical pharmacologists, we design a trial or a pharmacokinetic study. Now, it is essential that we collect the right samples at the right time points. There's nothing more heartbreaking than reviewing somebody's work and realizing it was a bit of a missed opportunity. So I always plead with people, involve a pharmacologist. We are useful. We need to have access to laboratories that know what they're doing with the assays, and I'm working quite hard to make sure that these assays are set up in country. And I have teams of mathematical modelers that can really understand the data. Then one little arrow, very important, that we go back into the communities and present our findings in a way that is accessible and understandable. So in this quite short 10-minute presentation, I hope I've persuaded you that pregnant and breastfeeding women do require medication. Not doing studies may actually bring greater risk, and well-designed studies, and maybe in the question and answers, I could go into detail about some specific examples, but they can change policy and practice and really make a difference. Thank you very much for your attention, and I look forward to the questions.
Thank you very much. Talking of questions, I was looking in the Q&A and I can't see any at the moment. So we've got around 42 participants. So please, type in your questions to any of our speakers, either the ones that have gone or the ones that are coming. Now, just a follow-up for you, Catriona. We're talking about the COVID-19 pandemic, and we've seen what happened around pregnant women and the possibility or not of taking the vaccine and the controversy around that. So can you perhaps sort of just say a little about how you approached it and how you sort of were able to reassure pregnant women around taking the vaccine and that it was safe? Because I know there are lots of questions, and I'm sure they would have come to someone like you with your expertise and background about, is this vaccine safe for me as a pregnant woman?
Yeah, and we're actually just responding to some reviewer comments on a paper on this exact point, because the COVID situation is quite fascinating, because what we saw is, usually as a pharmacologist, I talk about risks and benefits, and I see a sort of seesaw with the risks on one side and the benefits on the other side. And early in the COVID pandemic, there wasn't that much evidence of benefit to pregnant women, and there were potential risks. This was a new thing. And so perhaps in the first wave, the evidence wasn't overwhelmingly in favor, but obviously as evidence accumulated, particularly with Delta wave, we started to see these adverse pregnancy outcomes, adverse infant outcomes, and increasing numbers of pregnant women who'd been exposed to the vaccine. So we started to see greater risks and greater safety of the vaccine. So the sort of seesaw started off one way and it kind of flipped over to be categorically in favor. How do you persuade people? I suppose there's the scientific facts, but there's also listening to people's concerns. Sometimes it requires more than one consultation. It's a dialogue. Somebody doesn't have to make a decision immediately. And I think it's being aware of that we give our patients time. I think that's a summary.
Okay, brilliant. And you've prompted at least one question so far, so that's really good, and we'll come back to that. And it looks a really interesting one.